I'll encourage him to participate.
Okay, great. And same for you, Gary.
Thank you. I'll try to be there.
Okay, great.
Hi guys, I'm back.
I don't know what happened to Rick. Oh,
I don't know what happened.
okay. I put my plug in, Rick.
Thank you, and I'm going to need you afterwards to splice 2 recordings into one, Jake. We'll figure it out. Anyway,
Okay, no problem.
sorry about that. I don't know. I'm not in my own home, and I don't know why I'm having issues today, but I'm largely here. So let me just take a quick look at who's on the call. I just want to make sure that everybody, I'm going to read down my list again, and if I've missed anybody, you guys will tell me, but I see Jake, Dennis Correa, Peter Kafka, Eric Binder, Gary, Sylvester Mann, Susan Johnson, Greg Harrison, Paul Frieda, Larry Fish, and Thibault Lincecum. Is there anyone that I've missed? Okay. So let me run down and see who's got something they'd like to discuss today. First of all, Jake, anything for you?
No, Rick, I'm good.
Okay. Dennis, anything for you?
No, nothing here. New.
Okay. Peter, anything you'd like to talk about before you leave us?
No, I'm good. I've said enough.
Mr. Bookbinder, how about you?
No, I don't have anything today.
Okay. Sylvester, how about you?
No, not today.
Okay.
Thank you.
Wow. Greg Harrison, I think you need to give us an update since we spoke to you last. Are you comfortable?
Well, thanks, Rick. I haven't been to the MO. My appointment is 22nd of May.
I just want to let you know we're going to check in with you because I just want to. I'm just sort of figuring out for time. Paul Frieda, anything for you? Paul? I see him there. Paul, are you muted or can you hear us? All right, we'll check in for Paul again in a moment. Larry Fish, anything for you tonight?
Something quick.
Okay, we'll come back to you.
Just,
And
yeah.
anything for you? This? Okay. And I just heard a ding. Was that somebody arriving or departing? No, I don't see anybody new, so.
Greg Harrison just left.
Okay.
Greg Harrison just left. She's probably going to try to log back on.
Okay. Yeah. Okay. Thanks for that, Jay. Well, since I was going to go to Greg Harrison first, and Paul, are you back with us, Paul Frieda?
Who?
Okay. Is that Greg that just called in?
Hey, Rick, I'm sorry. I had to, my phone would not let me talk. It kept screwing up here. It's Greg. I'm back.
Okay. All right. So, Greg, why don't we kick off with you? Because we seem to we'll have some good time here. So why don't you tell us what's happened since we last talked to you?
2 weeks ago. Let's see. So I have had one new hot spot on my spine that appeared Saturday night. By today, it has kind of faded, which they kind of do when you get metastatic bone lesions like this. They kind of they'll appear and then disappear and then they'll appear again, depending on what you're doing or what's going on. But the good news is it's the first one I've had on my spine and on my spinal area, and this one actually showed up for a couple of days and then went away. I can definitely tell the difference between the bone pain from the cancer versus, muscle aches and pains. And my wife's constantly asking me, "You sure that's what it is?" It's like I'm gonna have to double check with myself.
Tell us,
Besides that, I've had pretty good energy.
tell us a little more about how you perceive the difference between the muscle aches and pains and the bone pain. I think that's an issue that will interest a bunch of guys, and certainly those who aren't on the line when they call in again. It's a really great observation on your part, and most of the guys we speak to don't discern it. So what is it that makes you feel that it's a different
I was a pretty active athlete for many years. I played college football. I played golf up until I was in my early 50s. Played on, slow pitch softball teams in my 40s and volleyball leagues at work and so I was very active, and I knew when I had muscle strains or you can kind of tell what a muscle strain or a pull or just regular body aches and pains feels like. Metastatic cancer bone pain, I only can describe it as if somebody has a hammer inside your bones. And it starts out like a ball peen hammer, lightly tapping. The pain kind of surges and leaves and surges and leaves and surges and leaves. But it definitely comes from inside. You can feel it in the bone. It's not, around it or in that area. It's actually, when you touch the bone, you can actually feel it in some spots. And then as that, if you've got a spot that gets, I've got a spot on my hip that's just drives me crazy sometimes. And as that gets worse, it becomes from a ball peen hammer to more like a chisel hammer, and it starts taking bigger bangs at that area. So I may have a day where I've aggravated a hot spot on my hip, and I may have to take 20 milligrams of hydrocodone that night to get to sleep instead of usual 5. This is a maintenance dose. But that's how I would discern the two. It definitely, I can definitely tell the difference. And when I got my bone scan done, nuclear medicine bone scan done in January, which is my 1-year follow-up when I started, and the 3 hot spots that the radiologist said had gotten worse instead of better, which everything else had pretty much gotten better, I could have told the MO what the results were before he ever even gave me the radiology report. All those left knee, left hip, left collarbone. The disheartening thing for me is the radiology report also shows starting on the back of my skull, which I have not felt until the last few months, little aches and pains in the back of my skull. I'm hoping that doesn't get any worse.
So have you seen Dr. Sarantopoulos since we last spoke, or are you about to see him?
No, I see him on the, he's actually, his mom passed a year ago this week. His sister is a oncologist at Duke. So the two of them were getting together with their dad he's away for 2 weeks. So I would have been actually going on the 15th for my regular 4 weeks. I'm going on the 22nd for a 5-week follow-up. I'll get my PSA and my labs, and then I guess we'll get a decision depending on, as the PSA drops since the Caregivers got added, has it actually ballooned again, has it stayed the same? He has to make a decision about what the next treatment steps are going to be. More rounds of docetaxel, or you're going to try Standy or Zytiga or do something else. It's just up to him what he feels that the
question to you was what your latest thinking is on where you're going next.
I think is it Zytiga that coupled with the prednisone? Is
Yes.
that the one that? Yeah, I'm thinking more on that line, but then again, I don't know. I think I've talked to a couple of people that have had some really good results. I got a couple emails from guys in You're Not Alone. Kind of now web page that are metastatic like me. I got one from a guy named Charles, and he's a little bit older than I am, but he had a Gleason. I mean, he had a PSA of around 5,000 when he was diagnosed 5 years ago. And he's just now become, in 4.5 years in, he became not hormone resistant, I guess, but they started them on the Zytiga and prednisone, and he says he's doing. Oh, I'm sorry, he's on Xtandi.
Mm-hmm.
But he's doing very well. He's got his PSA down to around 7 in the last 5 months, and he's feeling great. And everything else is kind of just, he's the bone pain has kind of stopped, and he's hoping that this works out for an extended period of time. But he's having good success. I was thinking about talking to Dr. Sarantopoulos about the test that Hopkins is going to run him to see what he thinks. Is it worth $1,000 to go ahead and get it run? Because it'll be out of pocket.
The big benefit is that if it turns out, from a financial standpoint, is that if it turns out that you are ARV7 positive, you're spending $1,000 to find out rather than going through 1 month or 2 months worth of drugs, which may cost you a heck of a lot more than $1,000.
Exactly.
On the other hand, if they tell you you're negative, then it's cost you an extra $1,000 to find that out. But maybe that's worth it to know that you might get some real time out of either of those two drugs.
Right.
So
I don't know. Yeah. So those are all topics of discussion with GMO on Monday, the 22nd. And if he decides, I'll bring the form and the collection instructions with me on the ARV7. If he says that's the way we want to go, then while I'm there that day, I'll just have him do the poll and get the blood out and get the result. It won't hurt to ask.
First of all, I'd like to know if there's anything you'd like to go through with us. But first of all, I want to throw this open, see if there's any guys that want to talk to you about this pain issue. Is there anybody on the call that would like to talk to Greg about being able to discern between the muscle aches and pains and the metastatic pain?
Yeah, hi, it's Larry Fish. This brought up a number of thoughts for me. The first was hard for me to know the difference sometimes, not specifically between muscle and bone, but I get a lot of bone pain. I don't know if it's from something that's metastatic or if it's something else. I had, for instance, rotator cuff injuries for 20 years. So the bone scans show it, but without a biopsy, how do I know if it's cancer related? And then 6 months ago, I started to get a lot of elbow pain and saw an osteopath who said, oh, it's reverse tetanus elbow, maybe from my form doing pull-ups on from the pull-ups. How do I know if that was like from just from repeated strain doing pull-ups? And then I had a trigger finger, and I thought, oh God, this thing is going from my shoulder to my elbow to my finger. And then I read that trigger finger is like a side effect you can get from Casodex. So I just like float with these things and never really know, is it something until you can get like a bone scan again. And even that, how do you know without a biopsy what is what? Because it's, as we get older and we exercise and gets these aches and pains, hard to just float with it, or when do you like take action and do something?
Well, that's what I'm kind of there's one on my hip. The one thing that scares the crap out of me, and I have personal reasons for it. I lost a good friend back in January with the exact same disease at age 60. And his story was he had a radical process 6-7 years ago. He was a Gleason 7, I think, and they finally killed it, and all of a sudden, he started having all his back pain, and he went in to see the neurologist. They pulled a PSA on him. He was like 300 and something, so they started doing chemo right away, and then after the chemo, he didn't respond very well. They had some spinal lesions. They put him in the hospital at Johns Hopkins for 35 days while they radiated his spine. And he never recovered. I mean, it killed him. A year later, he was dead.
Yeah.
So I don't want to get into the radiation for the bone meds until I really need that palliative care. If I can control it with pain meds, I'm going to do so. I don't want to have to go to... Go ahead.
No, it's okay. That's exactly where I'm at. I mean, I had that terrible, I found this thing because I thought I had a hernia or hip pain. I was thinking I was doing the wrong kind of sit-ups on the wrong kind of sit-up machine. And then that progressed to MRIs and the whole thing. And Lupron seemed to have wiped out that pain for the last couple of years. And now it's more or less arthritic aches. And I do the same thing. I like get HC and I take it. I try to, and I denied the radiation. I got sent to the radiation oncologist, but then I saw someone in Boston and they said, well, just get a bone density. You don't need radiation until there's a specific reason. And you can't radiate everything. You don't know like
Right.
how many places this thing is. And nothing has reached that place yet where I'm ready to do it. So just when you were talking, it sounded so similar to where I'm at. And just wondered, like, well, do you keep biopsying things or suggesting that, or you just wait for the PSA to get really high and work everything off of that?
Well, I got, I was down there after my docetaxel finished in October. My last PSA, then the chemo was 1.5. Then it went to 3 in December, 7 in January, 14 in February, add Casadex, 14 in March. 22 in March and 48 in April.
Oh,
So
sounds scary.
I'm doubling like every month. So obviously it's aggressively coming back after the chemo. And if my MO tells me in 2 weeks, you really handled docetaxel well, which I did. I had a couple bad days every 3 weeks, but that was it. I lost a hair, but that was, I didn't really struggle with it. If he says that's the way to go, and get this thing knocked back down again, I'll do it. But if he says we're going to try something else, I don't know. I've heard there's guys that have had 20 rounds of docetaxel. I don't know. I just don't know.
Have you gone through all of the Lupron, Xtandi, that route?
I have not done Xtandi or Zytiga yet. I've been on Lupron since April. I was diagnosed in March 2016. I've been on Lupron since April. I was on Casadex immediately upon the biopsy. But as soon as I got the pathology report, the urologist put me on Casadex. I went from 650 to 140 in like 30 days and just dropped it, felt like a stone.
Wow.
And then Lupron kind of wheeled it back down to like around 12 when I started chemo in July. Then the chemo brought it down to 7 the first month, I think, and then all the way down to, like I say, 1.5 end of October. But then it's got back up. The last 8 months, it's just got back up.
As Rick, always says, Richard Davis says, and everybody says, and I say, I'm certainly not a doctor or anything, but it sounds like with the speed of the doubling time and everything, that a medical oncologist might want to consider some other options, like quickly before just going back on chemo and seeing if
this next my visit in 2 weeks is basically a crossroads for me in my treatment because I'm at 48 now. If I go in again and it's up to 100, it's doubled again. Then we need to make some decisions. It's still at 45. What do we want to do? It just like somebody said earlier in the call, there seems to be a lot of crossroads in this disease. It's like a lot more than anywhere else. It's like, okay, well, I'm here. What do I do next? What do I do next?
Well,
I'm only 58. I'm 59. I'm still young. As far as I'm concerned, I don't want this to be the last 2 years of my life.
The fact that you responded.
Which someone else would, I don't know how to ring in. So please, Richard.
The fact that you responded well to the chemo, if that treatment works for you, there are men who, we know men that have done 40, 50 chemo treatment. And, and Jeff Tanner, for many men, is a less invasive treatment than the docetaxel. But it might be that you did fine. It would be great if you did fine on that. And again, why reinvent the wheel? Down the road, the abiraterone or the enzalutamide might be a good option, or whatever else we come up with. But as long as you feel you can tolerate the chemotherapy, it becomes an option for you that many men wouldn't.
I think my MO. I think my MO. I think he's of the school that he tries to keep as many arrows in the quiver until he has to use them, sure that he needs to play, because that still gives us lots of options as long as, he doesn't use options. So I think that's kind of, was his thinking of going back on Caregivers and see what that does, because we've already done that. We knew it worked. And now, if he tries to do docetaxel, maybe he'll try a couple rounds and see what brings it down. If it doesn't, then we do something else. I don't know. But like I said, these are all options, and we're going to discuss them on the 22nd, and I'll let everybody know that week what's happening.
Eric, do you have anything to contribute on this pain question?
Well, I started to get bone pain at one point. I had pain in my back where I have my mets in the thoracic spine, and I did get radiation. So there's four T1, 2, 3, and 5 that are metastatic, and I had each one of them radiated. First the 3, and then number 5. And it took away, they were painful, and that took away the pain. They specifically did it, for the pain. There was no thought that it was going to make the cancer go away. But since then, I've been pretty good. I have a little bit of pain in the spine. I get other pains, and I do take Norco for those, 10 milligram hydrocodone with acetaminophen. And they talked me into I take one each morning, and then if the pain gets bad, I take another one. And the most I've ever taken in a day was 5, and I usually just take 1 or 2. I was worried about addiction, and the shrink said, look, you got pain or you got addiction. He says, if you get addicted, worry about that. But right now you got to worry about the pain. And I'm not an addictive personality, so I really wasn't too worried about it. But probably that's why I'm not getting addicted, is that I do worry about it. But I haven't felt any dependence on it. But it certainly makes all the difference when I do. I get these general pains that sort of they're in my whole body. And I couldn't really describe what it is. It's kind of like having the flu, Yep. When you get the flu and just everything hurts. Yeah, I get that. And then I take a Norco. It takes about 40, 45 minutes, and it's gone. It's completely gone, and I feel so much better almost every time. There have been a couple of times when that didn't do it, but that's how I've been dealing with it, and it's pretty successful for me so far.
And how about Dennis? Dennis, have you been symptomatic at all? I know your disease is metastasized, but have you been symptomatic at all?
I don't think so. I have a lot of osteoarthritis, so I have pain from time to time in just about every joint in my body, which I've mostly attributed to my osteoarthritis. And I have the same anxiety about every time I get a new pain. Is this, the cancer spreading, or is it just my osteoarthritis? So it's an issue for me, but I'll just, take ibuprofen or Aleve or, something like that. Actually, the days that I play golf, I do take 2 Aleve, which my doctor recommended some years ago, just for that pain. And the main issue I have is generally when I wake up in the morning, every joint in my body is stiff as a board, and when I move it, it hurts. But mine are my lumbar spine is where my mets are 5 mets in the lumbars, and then 1 in my right upper femur. And to say that I can determine that I'm having any cancer pain, I don't think so. I do have, musculature pain also in my back from time to time. I'm doing some other things for that, like the massage, and also the Flexamend. I think it was maybe the stuff that the herbal thing I mentioned last time.
Right.
Zyflamend, I'm sorry. And it's not getting any worse. And I know a lot of these things like the massage and the Zyflamend, they're only good at the moment. I guess when you're getting it, the Zyflamend takes a while to work, a couple of weeks before you start to see results from that. So yes, it's an issue of mostly of anxiety. Most of my persistent pain I've got in one elbow. I know how that happened. That's probably a tendon thing. I was doing something in the garage and felt something, and that's persistent. It's been there for several months. And then one on my right shoulder, the same thing. I knew what I did and what's causing that pain. But the back pain is kind of like, I guess it's a type of a stiffness pain. And that I'll just, it comes and goes. It's not persistent. And it just feels like it's something I can deal with. But it's always in the back of your mind. Is it the cancer spreading again? Because my PSAs have been going up slowly.
This whole issue over the management of anxiety and stress, I feel like it's a subject that the doctors never really talk about, and I haven't seen a lot of literature on it, and I think it's terribly important because the more anxiety and stress you have, the weaker is your immune system, and when your immune system gets compromised, the cancer spreads. And in a way, I feel like it's a very fecund and productive, prospectively productive area of research, and I really don't know why we haven't seen more. I mean, I may be wrong. I mean, maybe if I Googled, there would be a lot more, but I just, in the years I've been doing this, I just haven't seen a lot. I mean, we always encourage men, as I said earlier to Susan Johnson, I mean, we encourage men to control the three things they can control, which are diet, exercise, and stress management. I mean, we know that the exercise can help a great deal with stress relief. We know that the diet can help a great deal with stress relief. The problem is the sort of foods that you want to eat for stress relief and not the sort of foods that are going to control your prostate cancer. So, we always say, as far as diet is concerned, I always say, look, you don't have to go on a strict prostate cancer diet. Every so often, eat something that you enjoy. Have a steak once a month. It's not going to kill you. And it's probably going to do you better because you're more satisfied and it's going to relieve your stress and make you feel good than it is going to harm you. And that's not medical advice and there's no basis for that. But I kind of feel like if we can encourage men to be happier and more comfortable and not feel like because they have prostate cancer, they're walking on a balance beam. We're doing the right thing. We also run this inner conversations call that we've mentioned already on this evening's session, and the reason we run that is so that it gives men the opportunity to air these sorts of subjects. Just the mere fact that you feel stress and anxiety, and you've got somebody that you can call and talk to about that issue. I mean, all the men on that call are very open and very willing to bat around how they handle stress. So, is there anybody on the call that would like to talk to this stress issue?
Was that Greg that was talking before, Rick?
It was, and he just left, I saw.
He just left us, yeah. I think he was having problems with his phone. He'll probably call back in.
Okay.
But he
Jay,
missed the last few minutes of what she said.
Jay, you want to talk about stress management a little bit?
You talking to me,
I am.
Jake?
I am.
Well, I don't know. I get under stress occasionally, but I have medication to solve that when it gets really bad. If I have an anxiety attack or whatever, I don't know. I'm probably not a good person to talk about that. I will say, as far as the pain goes, though, and I don't know if this is true, but my doctor told me that pain from cancer does not move around. It's generally, it doesn't appear one day in one spot and then another day in another spot. That's not usual for cancer pain. She says cancer pain is usually, stays in one spot. And I wish Greg was still here because he mentioned hammering pain.
Yes.
That sounds to me kind of like nerve compression type pain.
Mm-hmm.
Especially if it happens when he moves or he changes position. He's pinching a nerve or something. Would be my thought.
Hey Rick, this is Len. I have a comment about stress or reducing stress.
Okay, welcome, Len. I saw you were on. I was just waiting for the opportunity to acknowledge you, but please go ahead.
Yeah, so first, I guess I should say that, or repeat what you always say, which is that if at all possible, we should all be treated at NCCN cancer centers, comprehensive cancer centers, where they have integrative medicine approach to prostate cancer and all cancers. For instance, at Sloan Kettering, every prostate cancer patient is offered the opportunity to speak with a psychiatrist they have there, Dr. Roth. I haven't done that, but I know a lot of folks who have. Richard Foodie, for instance, has done that, and he says it's helped him.
Mm-hmm.
So that's number one. But what works for me personally is mindfulness meditation. I'm sure everyone's heard about this. It's been in the news a lot over the last few years, and I think it's an effective way to help reduce stress and anxiety by focusing, being in the moment, as opposed to worrying about the future or dwelling on something in the past. So, yeah, that's about it for me.
I have to endorse what Len said. It was a great help to me when I was going through treatment to have mindfulness meditation as a tool in my bag, because if I felt stressed, I would just make myself sit down and breathe and meditate a little bit. It so happened it was at a point in time when I was regularly attending a sangha, and so I was doing a lot more meditation than I do. The other thing, of course, I found is that some certain exercise that you do can also have that same effect if it's repetitive exercise. If you're on a rowing machine or a treadmill or somewhere where you basically don't have to be too alert as to what's around you because you're stationary, a bicycle, then you can use that to replicate a meditative state. I mean, rowing is great because there's a constant motion. It's almost like a walking meditation. but the idea is that you empty your mind and you just focus on what's going on right there, and so you don't have monkey mind, and your mind doesn't run away with you, and that's what causes the stress. You're worried if you're going to be here a month from now to attend a social gathering, or how things are going to get handled when you're not around. I mean, all those things, they're all real, viable concerns, but they make you crazy. And while you don't want to be putting them to the back of your mind, you only want to be thinking about them when you choose to think about them. And so, like Len, I encourage you to look into these sorts of practices, because stress management is a huge part of controlling your cancer. Thibaut, can you hear us? Are you with us? I think what probably happened is he logged on and then he got distracted by his kids, and he's there. Are you with us, Thibaut?
Yeah, what were you saying?
I was saying a couple of things. We've been talking about pain. I'd love to know we'd love to hear your take on pain. We'd love to know what's going on with your bone marrow trial. And we'd love to know how you deal with stress management. You can start wherever you like.
All right, I'll start with pain. I am 45 years old. I was diagnosed 3 years ago. I've been getting bone scans, and they have. I started out with some redness in my right hip region, and I started getting bone vets 1 year ago. That was 2 years after diagnosis. And I started having upper back pain for the first time a month ago. I had lower back pain, I guess, a couple years. But this upper back pain is different, and I'm thinking that's the bone metastases pain. And I started using ibuprofen patches, which are for me an NSAID, and I found that if I take a lot of the pill form, I get one day I took more than I usually do, and had some bleeding. So mostly I just use the patches now, and every now and then, I guess the bone pain in my upper back, for a week it was really mild, and then I really had to move one day, so it didn't even work, and so I got a prescription for oxycodone after that, and I take that occasionally as needed. And then like a week ago, I had hip pain, worse than ever. And it's right in the same spot where I had arthritis, but it was like radiating all the way down my leg, and I couldn't walk without a major limp. So, and I was running out of the 5 milligram oxycodone, so I asked the doctor for some 10 milligram. Now I've got a big bottle, and today all I needed was the one patch in the morning, and I was okay. Any questions about that?
Yeah, anybody? By the way, I've just taken my video off because I think I'm pushing on bandwidth here. I don't know what's going on, but anybody like to come back to Thibaut on pain? I do have an issue. I mean, do you, like Greg, do you feel that you can distinguish the difference between metastatic pain and muscle aches and pains?
No, I'm not totally sure, but you know, I never had pains. It's been a month now, and I still get this upper back pain off and on. So I think because I'm that long, it's just probably not muscles. Yeah, the first week, I thought maybe I just pulled a muscle or something, but now I think that's not likely.
Anybody want to talk to Thibaut about pain?
Well, I also have a similar kind of experience, Larry. It's Larry, and sometimes I think, well, this is part of the Lupron side effects, and it's not. Well, maybe it's not Mets. Maybe it's just the way that Lupron goes. After now, it's been just around 2 years on Lupron, and I'm afraid that that's what's happening.
That's a good point. I haven't the effect of your bones, so yeah, I'm not feeling them. The disease exacerbated by the ADD. My signs of degenerative disease in lots of places. That's
So anyone else before I move
Rick,
Thibaut on to tell us about?
yeah, I have a comment. Rick, yeah, I'd like to ask Thibaut, is it possible that the pain in your hip that you feel running down your leg could be sciatic nerve pain?
yeah. The description I read of feeling, but it's sciatica is a symptom, right? Doesn't it have some other cause?
Right. But they can treat it with either chiropractic manipulation or physical therapy, assuming it's something different from your metastatic pain.
A good thought, maybe. First, almost.
I can't hear you.
Yeah, you're cutting in and out, Thibaut. We love to see your face, and you look terrific, but I think it's using up too much of your bandwidth. So we're losing you a little bit on your sound.
All right. Is it better now?
Yes.
Yes.
Anyway, yeah, doctors in general, but maybe.
No, we lost you again. You're cutting in and out on us, which is a bummer.
Yeah. But actually, when I had the hip pain recently, I didn't go see him. I just called him on his cell phone and asked for stronger pain meds.
Uh-huh. And when you say him, is that Sam Denmead?
No, my primary care doctor is the one that prescribes pain meds.
One thing that's a puzzle to me, and maybe you can get more information, is that when Susan and Ron went to Hopkins a couple of months back, they couldn't find palliative care support or symptom management support. And I'm sure Hopkins has to have symptom management support. Have you ever talked to them about having a symptom management person on board for you?
Well, they have a team that but patients or people that they don't really focus on that for outpatients, as far as I can tell. And at least one of my all the different pain options. So you're better off going to your primary care doctor for that. I'll just focus on the long-term cancer treatments.
Mm-hmm. I mean, I know that, at certain other hospitals, certainly at UCSF and at Memorial Sloan Kettering, they'll assign a symptom management person to you, and they really perform that function that you're asking your PCP to perform. And they're, to some extent, better at it because they're a lot more experienced at it. I don't know. Oh, Dennis Correa, you like to talk about your palliative care support or your symptom management support at U of A, right?
Yeah, again, that's another reason I chose that location. In addition to being local and close by, they have a full complement of supportive services for their patients. I too was offered, if I get to the point of my psychological stress being too strong, that they have a psychiatrist there that I could talk with. And when I've seen my general supportive care doc, she always reminds me and asks me how I'm doing relative to, that type of stress. And so far I've told her that, to me it's fairly manageable. It's not something I can't handle at this point. But yes, and as I said, they also offered, the massage, the acupuncture, lots of palliative care.
I'm pretty.
And it's all in one place, and so the doctors are all on board together with my oncologist there. So nothing is going to be conflicting with what my primary oncologist care is giving me. So.
Yeah, I'm pretty sure that Hopkins has an integrative. I'm not 100% sure, but I seem to recall that they do have an integrative cancer health group. Maybe we can. I don't want to look for it now because I just don't have. I'm using my little computer and I just don't have the memory to run other things at the same time. I have to ram on this, so I don't want to push my luck. But having said that, I mean, we'll look, and Thibault, I do encourage you to look, to search and see if Hopkins has an a cancer integrative care program, because that's where you're going to find a lot of the options that some of which we've been talking about tonight.
I'll do that. I'll ask about it next time I'm there.
Yep. So, just give us a really quick update. Anything new on the bone marrow trial?
So they gave me, this handout about bone marrow transplants when I signed my agreement to do the trial. The trial doesn't really describe the process. And they gave me the bone marrow transplant coordinator, which is, separate from the research trial coordinator. Gave me this folder describing the bone marrow transplant process, but it's totally wrong. Like, it describes the normal way of doing bone marrow transplants, where they're treating leukemia and they give you a whole bunch of chemo, and you're an inpatient for a while, and then the bone marrow transplant is just to restore the old immune system you used to have. Mine is nothing like that, apparently. I finally got a phone call from this coordinator, and she didn't start with an overview. She's just like, okay, what are your questions? And I had to pull the information out of her. Apparently, I'm not going to be an inpatient at all. I'm supposed to go there every day for like 4 months and go home at night. And I guess that's considered okay because my immune system's never going to be completely gone. It'll just be weakened by the lower level of chemo they're giving me. But I'm not allowed to drive myself because of the chemo, and I'm not allowed to bring my kids along either. So my wife can't be caregiver for my kids and me.
Mm.
They can't come in the daytime, and if I need to go in there at night for an emergency, I need to have somebody else to take me that's ready, you know, to go 24 hours a day, and we can't bring the kids along. So that was disappointing. And she was like, "Do you want to take a step back?" Like acting like I wanted to not do the trial. But I said, "No, I'll find somebody. Don't worry about that." So it looks like we're going to get you know, a couple of relatives to take turns living with us, and either taking care of the kids or driving me.
So don't forget, and we talked about this, I think, last time, don't forget the American Cancer Society. They have a ride share, they offer a ride share, not a ride share, a ride service on a voluntary basis. If you go to acs.org, oh no, sorry, cancer.org, that's their website, cancer.org. You'll see it right on the front page, things that we do, and one of them will be rides. And it may well be that they can help you, not every day, but they may be able to help you a couple of times a week, once a week, whatever it is. It makes it one less time which someone else has to help.
Well, this is every day for 4 months, and it's a 45-minute drive, and then spending a couple hours there, so it's, you know, at least half the day.
No, I realize that, but what I'm saying is you may be able to schedule American Cancer Society once a week or twice a week to help you out. The other days you may have to figure yourself. But
Yeah, I could do it. I'll look into it.
Will you? Just remember cancer.org, and I'll put it in the chat box just to remind you. Just remember cancer.org, and it's right there, I think, on the very front page. There's a ride service, and you kind of register, and then they have volunteers, and the volunteers know they've got to take you, they've got to hang around, and they've got to bring you back.
And the other bad thing the coordinator told me was that of the list of 6 potential donors that I gave of female relatives, basically they all suck except for one, that they're too old. And so we're just hoping that one is going to be a match. And if not, I don't know if I'm going to be able to do it at all. But a couple of them are only like 60, 50, 50s.
Mm-hmm.
Seems like that should be acceptable, but apparently not.
Well, I don't have any suggestions on that one other than to maybe do a genealogical tree and see if you've got some unknown female relatives out there that you weren't aware of.
Yeah, that's what she said. Can you think of anybody else? No, I'm pretty sure you know, my dad doesn't have any daughters that I haven't heard of. I asked him though, you know, he's like, no, I was pretty careful. I don't think I have any other kids.
How many brothers and sisters does your dad have?
He has a sister. She's like 5, and my mom's 74. My mom's the only one that's guaranteed to be a good enough match.
Right.
But she's old.
Yeah.
And then got a couple of cousins that are around 60. But so we're just hoping my niece is going to work out. She's 27.
Perfect. Perfect. All right. Well, listen, I'm going to move on. I've got a couple of advertisements to make, and I also want to check if Larry Fish had a question. Did we answer your question when you spoke, Larry, or do you still have a quick question for us?
No, I think it's very quick. It's like, is there a big price difference between the ultra-sensitive PSA and the regular? I mean, my doctor is such a pain, my local one, but my primary doctor I think that is more willing.
Right.
Is there like a price difference, or is it complex to get?
It's not complex to get, and yes, there is a price difference. I think it's something like 25 versus 75 or 100, I think.
Oh,
But here's the thing.
it's nothing. It's not. No, I mean that's nothing.
Okay, but let me say this. Remind me again. I have your number right up in front of me. What's your current PSA?
0.2.
Yeah, you know, probably it would be worth getting the ultra sensitive for you. On the other hand, I can tell you that I know people with metastasized disease at low numbers who have gotten the ultra sensitive and then they curse it out because it makes them too crazy. So, you know, is it going to make a big difference whether you know whether that you're 0.025 versus 0.024 when you're still 0.02?
There's no zero. It's just 0.2, 0.2.
Sorry, 0.25.
And it will make a big difference to me. And I do want to know if I can. Yeah.
Well then,
I'm trying to calculate my doubling time, and I went from 0.1 to 0.2 in 3 months. But who knows? It could have been 0.19 to 0.2.
right. So okay, well just insist on an ultra sensitive test.
Okay. Yeah. Thank you. I just wanted to understand the price or complexity.
And you could get that. You'll get an ultra sensitive test automatically at Memorial Sloan Kettering. So, you know, maybe it's just worth a trip into the city to have them do your test.
Yeah. Okay. Thank you. That was my question.
Okay. So, just a quick reminder that we have this precision medicine call tomorrow, which is going to look at genomic sequencing and the difference between genetic and genomic. And we're going to have some really good people on that panel, including Bill Burhans, and also another woman who is a doctor who has benefited, as Bill has, from identifying a personalized drug, a drug that's used in other cancers, but not their own cancer, and they've been able to use it and they've gotten good results. We're going to have a doc from Foundation Medicine and another medical oncologist, general medical oncologist who uses this process. This is not going to be a prostate cancer specific call. It's just about genomic testing in general. And then Mike Scott, some of you know the name from Prostate Cancer International, is going to be on the panel. We're going to have a heck of a lot to get through in an hour, and a lot of people that will want to speak, but I'm hopeful that we'll be able to do that. I sort of assembled the panel and I'm just moderating, so you won't have to listen to my voice talking about it, anything significant, I hope. If you haven't already registered, there's a link in the mail that I sent out. And you could probably not necessarily RSVP, but if you do, then you'll be sure to get a link to the program later. If you can't make the call, you'll know where to listen to it later on. Of course, the only advantage to listening to it live is that you can ask a question if you can get in. So that was the main thing I really wanted to say. Next Monday, which is our next meeting, I've got a feeling I'm going to be on an airplane. I didn't realize that until I just said that to you right now. Is next Monday the 15th, gents? Yes. Okay. Well, next Monday, I will physically not be able to moderate unless I don't think there's enough bandwidth to do it on the airplane. There might be, but I don't think so. So I will arrange for a stand-in for next week by hook or by crook. Somebody will stand in for me. And then the following week, I will be in Europe, but I should be able to handle the call and so on. So that's it. That's all I got to say. Anybody else got anything they'd like to talk about or mention before we finish up tonight? Okay. All right. Well, have a great week. And if I cannot speak with you on Monday, have a great 2 weeks. And you can always get a hold of me by email. You know how to do that. And we'll talk again very soon. Okay. Good night, everybody.
Good night,
Good
Ray.
night now.
See you all.
Stay on the line. Okay. Hold on a minute. And should you, well, no, you're gone.